Well, we're gonna go ahead and get started. So this, our Care That Fits conference is in September. And when we looked at this year, it coincided with the 20th anniversary of the Knowledge and Evaluation Research Unit. So just a brief history, and this is with the intent to give Oscar time to join us if he chooses to. There he is. Yeah, hurry up. Yeah. So just
Good breath, Oscar.
so but in November of 2004, we two things happened. One was we got our first contract with the Endocrine Society to conduct systematic reviews about testosterone use for their guidelines. And we had a meeting in the Public Library of Rochester to start our first patient advisory group. And although we don't have a formal date of birth, I would put forward that those two events mark the birth of the care unit. The it's I was in Canada coming back from a fellowship with Gordon Guyot, who I think you will meet today. He should arrive in the afternoon. And I had to, it was a 2-year fellowship, but in the second year, I had to figure out what I was going to do as a researcher coming back to Mayo. And it became very clear to me when I was working with Gordon that I was very good as an educator, but not so good as a researcher. And so that meant that I had to figure out a way of conducting research that would not bring that much attention to me as a researcher. And I think we've done all right. The work coming back meant analyzing what did we have a lot of at Mayo Clinic. And we did, my analysis led to identifying two things we have a lot at Mayo Clinic. One is surgeries, and the other one is clinical encounter. And so the knowledge, which was about understanding how evidence is produced, synthesized, and used in practice, and encounter research unit was born. So that's the knowledge and encounter research unit. Along the way, the unit evolved to include other forms of research that did not involve the encounter. And so we switched the name to the evaluation, so knowledge and evaluation research unit. And there's a strong current in the current members of the unit to try to perhaps go back to the knowledge and encounter research unit. And a strong emphasis that you've heard in some of the presentations during this year. Over the years, we've had several investigators join our unit. Our unit is not the typical Mayo Clinic research unit with one investigator and a bunch of other junior people supporting that investigator, but it was set up as a cooperative where investigators, didn't matter what topic they were investigating, but could come together in this cooperative to work together. And these investigators had to come together because they shared values. And so this is a unit that started by making explicit what will be the values of the unit. And then people that espouse those values could join. And there were 3 values that we set up at the beginning, remain to this day. One was patient-centeredness. So if you did studies on cancer or diabetes or primary care, or as long as it mattered, as long as it was experienced by a patient, it was pertinent to our work. The second principle was integrity, which had a number of different ways of becoming important to us. But the key one was that we would not compromise our independence, particularly as we were doing guidelines and shared decision-making work, that if we had in the past or in the future potential commercial financial support, that would become an alternative explanation for what we would do either on the guideline side or what we would do on the shared decision-making side. That's been a real trouble as a lot of funding has shifted from federal funding or foundation funding to industry funding, and we've decided to keep the unit away from that. There are obviously other factors that contribute to integrity as a core value of the unit, but that's been one that's highlighted. And then the third one was generosity. And that is the best analogy for generosity is a hug. So we talk about, let me give you a hug. You don't give a hug. I mean, if you give a hug and the other person is not giving you a hug back, that's kind of abuse or some sort of breach of personal space, right? It's kind of awkward. So uh, a good hug is one that you actually give and receive, isn't it? And I think that generosity works that way. It's not a one-way street. It's not like I just keep giving, giving, giving until I'm spent. Is that you give, and usually not only do you have the joy of giving the gift, which is, if you think about it, that's where we get the majority of our joys, is when we gift somebody something, and we see their faces light up. That's where we get most of our joy. But it's also the possibility of other people giving back. And this session, yeah, I think is in part inspired by that value. We're going to hear some up from our panelists, distinguished panelists, about how did it go? How did the hug go for them? You know, what is it that they got out of the unit, and what impact they think that the care unit in their professional lives, what impact the care unit has had in their professional lives and their ability to do work, potentially in care and to patients, if that's even possible. And I think that will be what we will hear today. Um, and then we're going to also get critical. You know, what are the things that we're not doing well? I mean, we're celebrating 20 years. Usually at age 20, you're lost. You have no idea what's going to happen to you in the world. You're filled with doubts. And so this unit should feel a little lost, filled with doubts, and trying to think about how it's going to mature. And one of the ways of doing that is to become introspective and think about what should we do differently going forward. So those will be the main topics of our discussion. To illustrate that there's room for a lot of improvement, Sarah McCarthy, Dr. Sarah McCarthy, who is not with us today, she moved back to Boston, but she was in our unit. And one of her key contributions to our unit is to add another principle, another value to our unit. In addition to patient-centeredness, integrity, and generosity, she asked that all our research be pertinent, that we shouldn't be wasting our time, our energy, our resources in conducting research just because it's there. It should be something that we do because it is important to, and it will affect favorably those who are struggling to get care or to receive. So we have now these four principles of patient-centeredness, integrity, generosity, and pertinence. I have to say, she did not use the word pertinence. She actually stated in a much more direct way, we should not conduct bullshit research. That's how it was. But I thought for this audience, I should keep it more elevated. Anyway, so I guess I didn't. So that's the unit. Over the years, we've had a large number of investigators come through to the unit and be principal investigators. We have a lot of people that have supported that research and become researchers on their own merits. The unit, for many people, is a station. And what I mean by that, it is a place where you come, you discover yourself, you figure out where you're going, where you figure out what are your own values, and you do it in a spirit and a place of camaraderie and co-mentorship. There are older people being mentored by younger people, and people of the same ranks being co-mentored with others, and that's how we've always done it, with, I think, quite a bit of generosity and humility. So maybe we should just go around. Can you briefly introduce yourself? And maybe say something about when you were in the unit, and maybe what is your one of the memories that comes to mind. Very, not a big long memory, just a quick memory. Something quick. Maggie, you want to start?
You were gonna go with the other side. My name's Maggie. I'm a designer and researcher, and I'm the creative director and program director for Patient Revolution. I started working with the care unit when I started working at Mayo Clinic, in the kind of first iteration of what became the Center for Innovation in August of 2005. And what was the other thing you asked? I'm sorry. Oh, a memory. Yeah. Well, the first one of the first tools I worked on, the sort of shared decision-making tools, well, was the kind of diabetes, issues choice, but I was actually thinking the other day when somebody was talking putting all the tools up, I was wondering if the bone density decision tool still has bones on it. Victor always hated those bones, so I'm unsurprised, but
I'm Summer Allen. I'm a family medicine clinician, or physician based here in the Rochester practice. And I came to the care unit. I'm trying to think exactly. And as I said to someone earlier, I base it off of my age of my children. It was before my daughter was born. So I think it's been about 10 or 11 years. And first came into it actually at a meeting with a colleague that had Casey Mamer and Ian Hargraves at it. They were sharing something a project they were working on, and it was the start of her ICANN. And I know it's, again, changed names to my life, my care, but it was fascinating to me. And I'd say a memory for me that has continued to replicate in other aspects of administrative work, research, and aspects that I've done, and continues in primarily what I do now and face-to-face care with patients was they had asked a question, they're doing that of what is my health or what does that look like? And I remember asking a patient, and it was the first time I really thought that when I asked the question, that people were just profoundly trained and educated to give me the response I wanted. Because I asked one patient and I go, "What does health mean to you?" And she goes, "That my A1C is at goal, my blood pressure is at goal." And I said, "Thank you. You have been well trained to answer this with what we've expected out of you, right?" But I said, "What does it mean for you to be healthy? What does your health mean?" Because again, we were exploring questions and trying to get things that was, and she goes, "Oh, well, no one's ever asked me that." Again, profound, because it's really what I should have, and again, for her, it was that she wanted to live to see her grandkids get older. She wanted to be able to make it to work each day that was meaningful to her, that was intentional, and again, it's just very interesting because again, at that point, I think I had already been in practice at least 6 years or so, 7 years, and then if you counted residency, almost 10 years, and that was the first time I was like, "Huh, should have been asking that a long time ago," so
So just to illustrate I'm sure there's a better word to this, but the promiscuity of the unit. Maggie and Summer, years later, with their different backgrounds, come together in a project that I think is one of the most meaningful ones that we've been involved in, where all right, where
it's short, so that's why I didn't talk about that one.
I understand. But this institution was struggling with how is it that patients in primary care continue to show up in the emergency department? Maybe we should punish them financially for doing so. That way, they're going to go back to primary care, which is, and we don't know how many more primary care services we need to offer, convenient and so forth, for them to stop showing up to primary care. And Summer and Maggie did an investigation that took them to be there, talk to people, understand patients, understand what their experience was about, and uncover that the reason patients were showing up to the emergency department is because that was where care was. When they tried to get into primary care, there was a phone line, among other barriers. Very few openings, and hours of operation and so forth. There was a phone line with, I don't know, it was 50 questions or something like that, at the end of which the answer almost always was, "I think it's time for you to take your child to the emergency room." And so people were trained literally to simply bypass that line and just to go directly to the emergency room. And the other insight was, if they did make it to primary care, they will see whoever. And so if they're going to see anybody, why not see a nice doctor in the emergency department? Because their doctor will never be the one that they will see them in that circumstance. And so it became very clear that our ability to care for folks was compromised by the way we had organized care. And that the reason patients were behaving like this is not because they were insane, but because we had trained them so that they knew where the care was. And it was in the emergency department. Am I saying that correctly?
The only other part that it made me think of when you shared this, as we're talking about shared decision making, you're talking about, again, what the care unit was founded on is the other profound part of that work. And continue to hear it all the time. And I just challenge everybody to think about it was the problem often that is perceived to be the problem in healthcare and or what is needed for patients is education. And again, Maggie smile. Our patients are very smart. They are not dumb. They have, I mean, again, we sat in workshops and it's the part that we say back all the time because, and continue to hear it when it comes to access to primary care. Well, we'll just educate them about their resources or we'll educate them what's available. They know what's available. It has nothing to do with that. Again, patients knew what the ER, we sat in a thing and said, tell us what the ER is for. They're like, oh, if I break my arm or if I got in a car accident, if I think I'm having a heart attack, right? All legitimate reasons to go. And I said, when was the last time you went to the ER? Oh, I went last week. Why? For my kid's ear infection. Right. So it wasn't, again, it's the wrong solution, but again, it's the easy answer that often is looked at in healthcare. Well, we just need to educate people. They're not smart. And it makes me think again back to how our system's been designed in healthcare. We often are assuming that patients, and I like to just call them as people, are not smart and they have no idea what's going on when they are actually profoundly and well informed and know about their bodies.
Hi, bonjour. Um, so I came to Care Unit in 2010. I was a PhD student at the time, and during a conference, I met this Peruvian guy who talked about clinical encounters and shared decision making, and was all the what we call now the Monterey effect. I was like, okay, this is where I want to go. And from there, I reached out to say, hey, this Canadian lady would be interested in coming down. So I came here to do a postdoc in 2010, which turned then afterward into a faculty and consultant position here. And some of my earliest memories, and I'm looking around here, and it's exciting because when I first came, our first meeting, and Victor talked of patient-centeredness, integrity, and generosity, which, if you remember, spells out PIG. So back in the day, the lead investigators were called pigs. So you can imagine people outside of the unit, and then they would come in and say, oh, is there an investigator here? And then someone said, well, I'll see whose pig is available, and which pig is available for you to meet. So the first meeting that I had with the investigator was like, okay, so you're our first female, our first woman investigator. So that's why I'm excited to look around the room now. And it's like, what are we going to call you? It's like, okay, Piglets. I still remember John Shelbert say, well, maybe we'll call you Piglet. And that went on for a bit. So it's not, I'm looking around and it's exciting to see everyone here. The second memory is Victor coming in and sitting next to me and giving me this book. He says, learn it. The book was called Element of Style. It says, learn English. I still have it you know what? I still have it to this day, and I give it to every single student of mine. I give them this book and say, you have no other choice in research but to know how to write and how to have your ideas and your voice heard. So to this day still. But on a more serious note, Victor, you mentioned that Sarah brought this up in terms of relevance and pertinence of what we do. But I think it was there. It's always been there, because as you know, as a researcher, you need to fight for grants, and you're thinking about your next positions and your grants and your papers, and you do want to make a difference, and you're really trying to make a difference. But it's hard because there's a lot of demands on you. There's a lot of pressure to be the best, to do what you can. So you're always trying to think what is next. And one of the things that I found coming here was that generosity of the guys back then sitting me down and saying, you do not worry about this. You worry about writing what matters, what's going to make a difference. And we're going to be there to support you. We're going to provide you with the resources to do so. And we're just going to do the best research that we can. And that's something that made a big difference for me back then, knowing that we had this safety net, which is not, you don't see that in many institutions, where you know that you can fail, where you know that you have people that's going to be supporting you. And that creates kind of this shared knowledge. And that's one of the things that I think one of the strength of this unit has been how we've shared resources, we've shared thoughts. I mean, this morning we were still meeting, and it's that generosity of thoughts and resources, which makes it that we're we're building on each other rather than competing with each other. And there's this shared knowledge that we're creating that just keeps expanding and expanding rather than being divided. And for me to this date still, it's one of the strongest value and one of the biggest strength of the care unit. It's his family.
One of the things that it's a memory that is not pleasant, but I'll share it because I think it's a consequence of all this. A few years back, 2013, maybe 2011, somewhere around that time. You might remember. I have horrible memory. There was a big change in the structure of Mayo's research programs for health services research, and there was a migration of the care unit into the structure of Mayo Clinic, and the let's put it this way. It didn't go well. And one of the things that happened is that several of our folks in the care unit found themselves in a very awkward position. And I think that one of the people that found themselves in the most awkward position was Annie. And I think we lost Annie, and Canada gained a research chair and a full professor and a true wonderful leader, because Annie was very poorly treated here. And that's been one of the most significant regrets in my career, is not have been able to protect Annie more. But I think now that it's things happen when you are resilient, and you are, and it's amazing what you've been able to accomplish. So it's that. Now talking about accidents, Oscar.
Okay, I'm Oscar. I'm currently working in the UK, clinical fellow in AI and geriatric medicine. So I was here in 2016 to 2018-ish, at the end of 2018, I think. So I learned so many things from the care. I think probably I have two events. So the first one, I think, is what I like the most about the care unit is that whenever I had like a silly or an idea that is probably unfeasible, I always had Gavi, and I would disagree with being pertinent, actually, because because I always had Gavi next to me who would be like encouraging me to do it or to find feasibility in my ideas. And I think that that willingness or drive of Gavi, which was also a research fellow or during that time, is that she always made me or made me grow or try to make me grow in a way that I didn't see that I could. And at the end I was okay, I know what I don't like, and that care also helped a lot. I know what I don't want to be doing in my life. And then finding what I want was easier when I left the care unit. And the second thing that I learned a lot from was Victor, when we were going to watch a game with the other Victor uh, in Minneapolis. I remember one of the things that Victor told me in the car was that we are always concentrated on studying the problems. We're talking about start to flow, I think. I don't remember, but then but we seldom do is how can we actually do something for the community, and that got stuck with me till now. And every time I try to do a project, I always try to how can we deploy it to the society? How can we connect people with what is outside the healthcare system? So I think those are probably the things that stuck with me the most.
Hi, I'm Spiridula. I'm an adult endocrinologist currently working in Little Rock. I joined officially the care unit in 2014. That was the second year of the endocrinology fellowship, where as fellows we're supposed to pick who's going to be our research mentor. At that time I was feeling I'm at this crossroad that I have to make the right choice. And I have to say that that choice actually led me to the best way to describe it is like the candy store. So I felt like when I joined the care unit that I'm a kid in the candy store. The reason I'm saying that is that you could feel the love, being welcome in the research team. But at the same time, it felt so magical. There are so many things to learn. There were so many projects that you can involve, and so many people around that can help you to learn. So I really remember the Monday huddles that we were having, which was at the beginning feeling kind of, how can I put it, like inspiring, and at the same time encourage you to do more, to do more for our patients, and help each other. I think that was the main message also during those meetings. Um, One memory that I had also stayed with me, I think Victor doesn't know it. There was a time that we were like, the unit is like an open space, and we were all like working each other. Doors are open, and so on. And I remember it was this day, I know Victor was working on a grant, and we knew that he is very, very busy. And I was feeling particularly low about something. And he had his door open, and you were listening to music and writing passionately, like standing on the desk and so on. And that picture has like, it was so impactful, because I'm seeing there someone I admire working hard but enjoying it, what he's doing, and like you could feel that he was so much enjoying what he was doing. And at that time I felt that moving forward, I always want to make sure that what I work on is something that fulfills me and actually makes sense to the world. And I think the other thing is that, when you do things, there are people that are watching you, so you always become a role model without even realizing.
So hello everyone, yeah.
If there are people in the room that that want to also, we couldn't put everyone here, but if somebody wants to share their experiences to start thinking about it, then raise your hand when we're finished here. But also, if you want to be prepared to start to think about asking questions, and you get the sense that this session is about, the research is not just about here's our findings, and this is that there is a culture, that there are values, that there's an experience. And so that's why we're hoping to, if you're going to do research on care, then you probably need to have a unit that cares, right? And so hopefully you're picking that up, but think about questions, and as you're hearing the presentation. Sorry.
Hi, Renee. I'm from Mexico. I came here 2015, 2016, after I finished my endocrinology fellowship in Mexico, and then came here to Mayo. After I left back to Mexico, we developed the Care Unit Mexico 2 years later, which we now have been running with Nelly for around 6.5 years now. And so for me, the Care was a life changer. I have tons of things that I could say about it, and experiences and anecdotes. Maybe I can share with you my first day anecdote, which was, you come from Mexico, you think about Mayo Clinic, the most important hospital in the US, probably in the world. You hear about Victor, as he said, he was pretty much in every guideline. So every guideline that you read about endocrinology, Victor was there. And you hear about Care Unit, which is like one of the most important, if not the most important, evidence-based unit in the world, alongside with McMaster, maybe in Oxford. And you think that when you come here, you're gonna see the Care Unit building, right? So I was expecting this 10 floor building, 20 floor building. We're getting to Plumber, it looks like the Care Unit building, right? 4th floor, and I remember going into to the Care Unit, and I remember getting in, and this cannot be. I got out. It was I don't know if you know the Care Unit, but it's kind of a small room, but yeah, have this size. So I went in and I went out, and I looked. I went in for it. I went in, I went out, and then look at the thing. It's Care Unit. It used to be. So, but the thing that were inside was just many times bigger than any building. So the things that we learned, the things that the people that work there, that have a privilege to live with for more than a year, pretty much was bigger than anything that has happened to me academically in my life. It changed. I mean, I think all of us share the shared decision, care. I mean, drop the medicine gene. Just make express this in our lives. And for me, it was a real life changer. Because the way I think about medicine, the way I even I'm as a parent. It's good. Microphone.
I think the microphone stopped working.
Yeah, the battery.
And making research that matters, right? Making research that really impacts people, not that it's something that you want to do because you want to succeed and be better and have better opportunities, but that if it impacts more people, then you can have those opportunities. I am really thankful for the care, for Victor, for all the persons that were here during my stay. And we have even a challenge to take that back to Mexico, but alongside with Neri, we have done our best effort to bring the care values, care work ethics to Mexico, and trying to build that unit that until now we have had some kind of success.
Having commented on Spiridula's, because I'm waiting for Nike's thing, and they're overlap almost completely in terms of the time they were together. But one thing about Rene and David that is now here is that Rene was a total surprise because he stays for a year, and all of a sudden he's winning every darn award that Mayo Clinic gives to research fellows. And I think you had like, I don't know, 3 or 4, and you had like whole spreads on Mayo Clinic magazines and all of that, and you were taking your pictures, and you were I think you had the most awards in the care unit until David. So now David is the most award-winning member of the care unit. So you just cannot fall asleep on your on your.
My name is Nike. I'm an adult endocrinologist, and I was in the care unit, I would say, from 2013 to 2016, because although our research year was in 2014, and that's where Spiridula joined, I think since I kind of like heard about the care unit and had some initial conversations with Victor and JP, I said, oh, this is definitely what I have to do. And then as a response to your prompt of if you were to think of a particular moment that you want to share, I just cannot think of a particular moment that I want to share. I think it could be one because of my own inability to focus on one thing, and then and then also because of my inability to follow instructions. Like I want to know them, but I don't necessarily follow them. So what my brain is doing as a response to your prompt is like it's bringing like a million memories, and like what I see there is like a bunch of people. And that's kind of like what I have. So not like a particular one, but just this sense of like a lot of people or a group that is there. And I would say that for me, many things that I did kind of like didn't work out. Like there was like a lot of failure, and still there's a lot of failure before things kind of like move a little bit better. So the unit was like this place in which I felt I went in with the failure and came out with like 10 other projects that I wanted to do. So it kind of like kept me moving forward.
You didn't mention it, so I have to do it. So we had this Christmas party at the Division of Endocrinology, and I got a sweatshirt that Spiridula and Nike gave me with 3 letters on it. And apparently, I am unaware of this. Apparently, it represented the most common response I gave to their ideas. So one thing that you will see, I mean, this is, Oscar will tell you 25 stories of this, is that, sometimes I go like, gosh, that is a horrible idea. You should not do this. And next thing you know, it's published in the New England Journal of Medicine, right? So I have very poor judgment when it comes to ideas that we should follow and which ones we should leave behind. And so all this thyroid work, you guys have done, with JP. It's like, what a waste of time. And all the next thing I know, the world is, completely changing the way it sees thyroid disease in pregnancy or nodules or all these things that you guys do. And I'm thinking, well, all right, I was wrong again. But apparently, every time they offer something, I say, meh. And so my sweatshirt reads meh. And so I still wear it with.
And I was gonna say, don't feel bad about failure. I will say the other award. Yeah, I forgot about this award till you said about a failure that I remember. I got denied by the IRB for a project, and Victor and Neela go, "That's never happened. You're the first. you are the first person that's ever happened to." And I said, "Awesome."
Hi, my name is Neri Alvarez. I am Mexican. I am from Mexico. I am a family physician from Mexico. I work in Mexico. I born in Mexico and I live in Mexico. So, thank you. Yeah. Well, many memories. Something I think the most important memory I have is that when I came the first or second week, I remember that I remember that I thought that how I came here after 20,000 more or less clinical encounters as a family physician. And I came here to learn shared decision making and minimally disruptive medicine from an endocrinologist or and that's something believe me, I think as a family physician I should or I must know how to share decision making with patients, and I didn't know it. I don't know if I mean I think I know how to share. I knew how share decision making, but when I came, everything was different. So I remember that that was something very important to me, and obviously generosity and all that kind of things. But to come here and really know that I am learning something important to my patients was and is something amazing. So that's something that I always say to Victor, and thank you very much for that.
There's someone else in the room that wants to add their memories or thoughts at this point? I'm happy to continue, but if there's somebody wants to, there's several people that might have something to say.
That sounds.
I was just gonna say that it seems there's a theme of the things that Victor thought it were a bad idea. And so the theory of patient capacity was one of those that I felt very strongly was where we needed to move into in terms of the minimally disruptive medicine work that we were doing. The reason being that there were a number of individuals at Mayo and all over the world that had started to understand and study treatment burden, but at the time, no one was studying patient capacity. And so I felt very strongly that that was the right direction to move in. But what I want to say about Victor as a leader, there are many places I think that when your PI or your mentor says, this is a bad idea, you shouldn't do it, the expectation is that you just stop that line of thinking. And in the care unit, I think everybody has the ability to continue to push that boundary and to try to do the things that they want to do. And I really think that that says a lot about this place because again, there are so many places that that wouldn't happen. And so I really owe so much of my success to Victor and the things that he has done to allow us to continue to push ideas forward.
That's a little weird, isn't it? Because you should have stopped.
Here we are.
I wanted to add, I think the value of building and rebuilding. I think in academia, we're kind of inclined to look at a project, someone sends a manuscript or an idea, and you kind of, that's not good, you should get rid of that. And we kind of destroy parts of the idea, but most people do not rebuild that idea again. And I think what I've seen working in the unit, especially when I was physically here, also because it's just one small place, so you cannot get rid of anyone, is that you sit there, you have an idea, you start talking about it, and someone takes away a few bricks of the castle that you're trying to build, but also makes a new wall somewhere else. And I really value that. And it doesn't matter whether it comes from a pig or from someone who just came in yesterday. There would be someone in a unit saying, what are you talking about? I think that block should be somewhere else. And I think that has been my biggest lesson. So if you ever have the opportunity, don't just destroy parts of the plan, but start to rebuild as well.
I can tell you that the first office that the care unit had was about as big as this console, and it had 3 or 4 people in that space.
It was a closet.
Closet at the end of a clinical corridor.
It was such it was a small place, but
Did have a treadmill desk.
so,
Those were super popular at the time.
one of my colleagues was into NEAT, non-exercise activity thermogenesis, which is basically fidgeting. And if you fidget, you're burning a lot of calories, so you can be all thin, right? So it will be a great explanation as to why there's people that are, bigger than others, is that the smaller people are fidgeting all the time, right? And so he popularized the idea that if you're on a treadmill all day long, you can keep trim. And then we heard that he had gotten a grant and upgraded his treadmills, but he had the old treadmill desks still available, and they were going to throw them away. And it's like, I like one because I like to trim. And then we put this thing in this little place where there are already 4 people. It's a closet, and I'm bringing in my big treadmill, and this thing was. And I'm like, I'm so happy, like spiritual, like I am so happy. I'm getting thin. This is great. And it was impossible. The place got hot, it got stinky, it was noisy. And some of people Becky Mullen start having fantasies of a Napico, where she was going to, you've seen those things where in the face of the mountain, somebody hooks up like a place to sleep. And she wanted to throw one of those out the window and just sleep on the side of the Mayo building, and which would have been incredible. We're going Natalie and then Mike. Yeah. No,
what I wanted to say. Oh yeah. So I don't think that Victor Montoy is all about like canceling ideas, because I arrived here because of you. Like, you opened the door for me when I was trying to do palliative care in Lima and I was getting the doors shut. So arriving here was great. Then I remember when you asked me, are you sure you're gonna get married? And then I didn't, but it was not because of you. But one of the first times that I start thinking about it. No, I'm kidding. I already decided that time. But then, no, but really, I think I appreciate a lot the fact that you always encourage us to do more than we actually imagine. And I think also the fact that you, for example, introduced me to Bjork, she's not here, but I learned so much from her too. And then, I don't want to cry. Yeah, it's just that when my father met you, yeah, he knew that I was like in the right place. And then you introduced me to Anya, and now I'm even like as good as I was here. So thank you.
Excellent. Mike.
Can you hear me?
Yes, we can.
Great. Yeah, sorry I'm not there in person. I've taken ill. But I was with the Mike Gianfrido. I was with the care unit from 2011 to 2016, and then I left and wandered the wilderness for a while, and then I came back in March. And one of the things that was was great about the care unit, or is great about the care unit, is just the number of people that come in and bring new ideas, and I get to meet them and learn from them, and it's been a really fantastic experience. I think I've worked with almost everybody in the panel up there, and it's been fantastic, and I owe so much to them and their generosity. I owe Nike a lot, and it's been great to work with all of you. And one of my memories is of Annie, well, of Victor. First, I'll do the first day story. I think the first day I joined, I had just finished pharmacy school. I'd come and I'd gotten the PhD program, and I wanted to work in Victor's lab, and we sat down and we talked about some ideas. And then he left for like a month to go to the Netherlands to ISDM. And so I spent a month working on a project that, once I presented all this information, I had this huge slideshow, and it was like, no, that's not really what we want. And ultimately, that project died. It was the hypertension project. But I do owe a lot to Annie as well, because one of my other memories is, Annie, I don't remember what we were working on. It could have been the hypertension stuff, but sitting in your office in Harwick and just going line by line through a paper and teaching me how to write and how to craft arguments, and the generosity, again, I just want to highlight, is a really important aspect of the care unit.
And again, for the promiscuity point, now it is Mike who gives away the book on how to read, just right, and among other books, right, Mike?
That's correct. Yeah, if you want a book, you come see me when I'm in the office. I'll give you a book. I have the Elements of Style, Annie, so.
Nice, but it wasn't Victor. It was also Victor who said, I don't think it's a good idea to take PhD students from CTSA. So Mike, we're really excited to have you.
You figure out these are people that are very resilient, who've been told no multiple times, and they still keep showing up. I mean, it's like go away, and they're like, no, we'll come back.
It's now part of the process. It's like, okay, I need to be rejected at least twice so that I know that I'm going to
Are
be
you
part
feeling
of
better?
it.
Is it only twice? Because it keeps happening.
Okay.
I just wanted to say, because I should have said at the beginning, but the kind of joint hug that I really love the care unit for is its embrace of design. And Victor and I met because in addition to running care unit, he was also the director of research for the Spark program, which is what brought me into that world. And we kind of saw opportunities in each other's disciplines and in working together and collaborating. And there already, for many kind of medical and clinical health services research groups, there's an enormous amount of diversity in this room. But I don't know if there's any other research group like it that has such strong roots in design and has embraced that way of thinking, as well as that way of making. And so I take a lot of pride that I was a good enough designer, that spirit and discipline was embraced here. And I'm so grateful for this community of people that I've gotten to collaborate with and learn from that is incredibly unique. And one of my greatest things I probably did was to help recruit Ian here. And I remember saying to him, I think, I can't really explain it, but I think this is something you'll never find anywhere else. And I think you'll really thrive here. And he has.
Yeah, and when Ian came in to interview, He chose to do something I've never seen in my life. So Ian comes in and basically first slide, and here's some of the tools you've been doing. They suck. They're bad. Next slide. This doesn't work. And here's how I would do it better, and this is how you move it forward. I know it's not exactly what it went, but but it was actually really interesting because this is my version of it is that it was an immediate the effect on the room was immediate. If we want to get better, we want to be able to clearly see where the opportunities are. And Ian came in and said, here's an opportunity, here's an opportunity, here's an opportunity. You never interview by criticizing the work of the people that are about to hire you. But Ian basically said, here's my value. I can make this, I can show you where the opportunities are and take you further. And 90%, I kid this, most of the things I say that are funny are actually not that funny, but they're all true. And one of the things, except this story I just told, and some of the other ones, but one of the things that is fairly true is that a lot of what I say has been said before by Ian, and I just pay attention and I just go and say it, and people go like, "Oh, that's very insightful." And I'm going, "That's Ian." And I think you're right, Maggie. I think I learned the value of design from you, and it was one of the best pieces of advice to say you must get Ian on. You want to defend yourself? What is going on here? What's this microphone?
I'm picking up a strong rejection theme that's running through this. I mean, it's like I stayed because I rejected you. No, how's this working? But no, I mean, I'm super grateful to Maggie. I mean, from our days back in graduate school, which paved the path to here, I've really just trod the road that you laid down before me. And I remember that presentation, and I kind of feel like I've been saying the same thing exactly for 10 years because I remember the slide, and the slide, as I reinterpret it now, is basically this is a decision A that's focused on one mode of purposeful shared decision making. This one's focused on mode 2. So it wasn't a criticism, it was a distinction of all the different ways you were tackling it.
Yeah, it felt like a rejection. Anyway, but it was it's the beginning of purposeful SEM, which is of course now trying to transform the way everyone else thinks about shared decision making. And that's the other thing I want to move into the issue of what could we do different. I mean, we need to look at the future, and the future, I mean, if you have seen it, not only is it to further develop what we mean by making care fit and the work of care that fits, but also what it means, how can we achieve that by making, and what can we investigate by doing it this way. But then there's all this new track, which is what Juan Pablo and David and Oscar and others are bringing into the unit, which is, okay, so this healthcare is going to be transformed by technology, and particularly by all these artificial intelligence systems. And so how are we going to make sure that care continues to be the main thing? And so that is clearly a new direction that I think, Juan Pablo very eloquently connected yesterday with the traditions of the unit into what will come next. So I want to give people an opportunity to think about what should we be doing different for the next 10 years? What should the care unit do different from what we're doing now? From your perspective, all of you have an outside perspective now. So what should we be doing different? Is that a fair question? And you don't have to go in order, but Neri. Conveniently.
Okay, yeah. Well, okay, I think it is working. Yeah, thank you. Well, I don't know if it is different, but well, at least in my side, in Mexico, yearly I have around 250 new students every single year. So they are medical students, they are master, PhD students and residents. They are 250 new students, and I try to plant a seed in all of them. I don't know if 250 will learn about shared decision making, but at least I know maybe 10%, maybe 5% or something like that, will have that knowledge or that, I don't know if curiosity, or they will try to improve the treatment with patients. So something important to me is that, well, Oscar yesterday told me, very old guy or something like that, because I am 41. So he said, I will finish my career very super old. So to like 41 years old or something like that. He said, but well, I'm not trying to work with, well, I am trying to work with very youngster guys. They are medical students. They are 19, 20 years old. And I'm pretty sure they are focusing and they can focus in the patient, not not as I learned that I remember I learned not that I am not focusing the patient, but that was not the main situation to attend. So I think that's something that we can do better, to focus a little bit more in the youngsters, to focus a little bit more in the medical students or not medical students, but very young people, because now they are not thinking in disease or something like that, because they are very young, but they will work and they will need somebody to help us, or they will help somebody else. So I try to do this last 10, well, 6, 7 years. I have been doing that, and at least I know I have been contributing with a little bit, but at least 100 guys that have in their minds this care that fits to the patient. So that's something that I really love to think, and I think we can work a little bit more with um, in medical schools or in something more basic. Or
Start them younger. Yeah, one of the consequences of starting people young is, when Oscar first arrived, he thought that, old people were over the age of 30, and that was real traumatic for many people.
Age was like 26. Sorry.
So say that again?
My recollection is you characterize people who are 26 as middle aged.
Oh, 26 or middle age, yes, yes.
Speaking of now.
Yeah, he may have changed his perspective. Good. What could we do different? Yes, Maggie.
I'm really interested in the care unit finding different ways to tell the stories of what's been learned and the conversations that happen here. Because I've been a part of a huge number of projects that I think have such interesting stories to tell, but they just don't fit into the model of a journal article, which I think always ends at the part where it would get interesting. It's sort of to my mind, like a lot of that like strips out all the most interesting kind of insights and things. And so sitting in Ian's workshop again yesterday, and then he and I kind of chatted for 45 minutes after, and I was like, I love this, and it furthers my own thinking in such meaningful ways. And I think finding other ways to bring the learnings here, both about from a project, the bigger kind of philosophical ideas about what it means to do this work, and also the way that the work here is done. I think the how readily this community saw the ability to figure out how to videotape encounters and how to create that collection of things to be studied and analyzed and looked at and considered, is all really powerful. And I think research papers are great, or journal articles are great for some things, but there's a whole part of the health community that's not getting to hear those stories.
And if I can build on that, because this is about exactly what I just wrote. which is that how, and it goes back to one of your comment, which is how do we create this capacity? How do we train the next generation? How do we embrace this and share this experiential learning? So this is what I had. It was that, how do we do this? Because it's not in the books, it's not in graduate schools, it's not in the paper that we write. I remember when we initiated, and I going back a couple of years ago, but with the Heather training, the Heather program that we did, bringing it, I think you were one of the Heathers, like I see a few Heather scholars here. Well, GP was one of the first Heather scholars, if I remember correctly. So how can we think outside the box and bring that expertise and ways of thinking that we can go beyond? And I know Care That Fits is a one-week conference, but is there other ways with everything's happening that we can continue to build on that expertise? And maybe my other point that I just want to bring in, I don't see Marlene anymore, but Marlene was talking earlier about from at the point of care to point of life. And I see that we're all thinking about that point of care, but the reality is that before we get to that point of care, there's life. And right now, I understand that's our focus, but how can we try to bring the next generations, the next society into opening more to having that critical thinking, that design thinking, and how do we work to increase health literacy, health numeracy, and go back to work? And I know this is totally outside the scope of care and of our group, but for me, it's been really something that has mattered in terms of trying to narrow those disparity gap and trying to help those that is needed. Because again, you can't expect when you're an adult to start engaging in your care if you haven't done so when you were younger and you haven't thought about being, what is the right evidence and what is the right information and what is my capacity to ask questions and reflect upon. And that's something that we've put aside at school, unfortunately. And I think that's throughout the system. It doesn't matter the country, but how can we slowly contribute to building the next generation of patients, but also of carer and of researchers, because these are who's going to change the world in a few years.
Yeah, when the unit started, two people were instrumental in advancing this idea of point of life in our work. One was Steve Smith, who is now retired endocrinologist as well, and Audrey Weimiller, who was a nurse practitioner and who led our statin choice decision aid, and Kirsten Vickers, who led the research program at the patient education section here at Mayo, who actually gave us our first grant. So she gave us, and the way she gave us, this is where generosity just hits you when it happens. So she gave us our first grant. She got a position as research chair. She got a chunk of money to cover her salary in that position. And instead of using it for her, she turned it into a grant, and we got the grant. And that was the beginning of our whole shared decision-making program. And we did a 100-patient randomized trial with $30,000. And that was on the basis of all the generosity of people. And to this day, I think some people are fully traumatized by the fact that we took a clinic, a whole clinic that was in the 18th floor, and we moved it to the 17th floor just because the 17th floor had cameras, so we can actually record the visits. And my colleagues, begrudgingly, but also generously, decided that they will support this, and they moved their practice for months to the 17th floor so we could do this. So it's all built on that generosity. Hassan Murad, who's not here, joined a little later, and I think he did probably the most about advancing education as part of our programs. And then when he had to divide and separate and carve out a safe space for all the knowledge synthesis people that he had done, which is a unit that was built once again on generosity by bringing people who had been devastated by the conflict in Syria, and giving these graduates of medical schools in Damascus, another place in Syria, the opportunity to come to Mayo Clinic and have a career. Many of them are now leaders in their own right in medicine. Hassan gave them a safe space for them to develop and to advance. And so talk about investing in young people. He invested not just in any old young person, but he invested in people that were that had their future essentially amputated by war and conflict. So there's a lot about investing in young people that we should be doing. Yeah. Who else has any idea?
Yeah, future. So one aspect I was going to say, and this Maggie just alluded to this about research that doesn't maybe fit right into the box, right? As she said, I mean, our work was almost 6 years worth of background planning, trying to work within the confines of a system, get them set up for exploration, and COVID hit. But her and I both, again, you think 4 years out from that, we reflected today again, getting to see each other, how much that work over those 6 years is still stuff that what we do now, we reflect back on those profound insights and how much it's shaping work that's done for her, for myself within the care unit and others. So we're determined and we will, again, even if it's 4 years out and doesn't have the right, when we've tried to put it into publication, the responses we get is, well, where's your data? Where's your proof that it worked? Right? Where's the proof of these insights? And again, it's the challenge and frustration, right? Because there's just not appetite left within the institution to do the experimentation or exploration anymore. But those insights are still significant. So I just encourage people to push past that part. And that's the part Maggie and I, and then a colleague, we had Michelle Lampman that had worked on it with us, that we're going to try to do with that work. I would say my part that I think for care unit and moving forward. So I didn't share this before. I came in also in part because I had been asked at a point at the institution to do, there was a population health and it was patient engagement, which still makes me cringe. It would make Victor cringe when we'd say it, because the concept of patient engagement is back to that patients are not engaged in their care. The assumption if you're trying to engage them, and so I would always change the words of into what did it mean to engage people, right? What did it look like? And then I spent time in patient experience, and patient experience versus say, even though I spent many years in that role too, is not the way, right? That's surveys and it just has its own parameters that it's trying to achieve, which is just a grade and a score. But again, how people experience care is my argument often to people, I think does impact how they engage in their care. And I am asking this question and said it in Ian's group yesterday and said it to our group of interested also in understanding how I was trained, how all of us is fundamentally at the concept of disease processes and organs, right? People being sick. I am trained to treat and manage people continuing to be sick, give them medications, give them more drugs, do this part versus helping them, which as a primary care doc is fundamentally who I am. I was a nutrition major, right? I chose nutrition, not biology, not other aspects, because I knew fundamentally, even in undergrad, that nutrition was going to be a significant impact in people's lives and I cared for them. So how do we start to look at what we do, right? It's not fancy and it doesn't have a special drug that I can test. And right now, but the best example I can give right now are the GLP-1 medications, right? That are infiltrating all specialties, all areas. It's the answer. And I feel like it was like when statins came out a little bit too, and you're seeing the effects now because it's the thing that people can get anywhere. Right? If we're not doing it with our institution, people can go on the internet, people can go to a local salon. I mean, they can get it prescribed, yet the long-term implications or the impact for people without addressing fundamentally and what's underlying for them as in their body and as a human, right, is just treating a disease process that doesn't help them with their access to healthy food, doesn't help them with how to increase their physical activity, right? It was just the fix, the quick fix, the Band-Aid to it. So I guess I would challenge us to start looking at the whole person versus a disease process. And I'm not saying that we don't, but you still try to treat it as disease processes if we look at it, right? It's the kidney disease, it's the high cholesterol, it's the atrial fibrillation. But again, how is that whole person? Because there are certain things that are going to require medication. I'm not saying that, but how do we look differently? Because I think that that's a part that we're missing. And it's the future generations as we talk about trainees. As they come up, I see so many of them missing that part, right? Like they're just looking at the disease process. They're not looking at the whole person. And they're also being trained more to, as we're trying to bring in shared decision-making, we said this in the group that, well, I asked them what they wanted to do and they didn't want to do it. So I just wrote that down, right? Like it's not passiveness. And that's their assumption. Well, I did share decision-making, so they don't want to. And okay, so I'm just going to write that down. No, have a conversation, understand what you're interacting with them, understand what they value, and try to alter the treatment plan or try to alter what you're offering based on that.
So person-centeredness, conversation, designing for problem solving, some of the key topics that we've been talking about. Yeah, I saw that. I also want to make sure that there's time if people have other questions or any other things. So don't feel obligated if you don't have any other thing. You feel obligated?
Yes. No, so I was just kind of like on thinking on the future, just borrowing, I think, on what Annie presented the other day. I think the unit might have some room to continue to grow and expand on the part that the project doesn't end when we publish and see that it's effective, but actually being able to translate those findings into practice to improve the quality of care and things like that. And then that might also not only require some of the things that we're doing, but also probably getting a little bit more involved with policy making, so that we can, as I presented as well, that all these decisions are happening in society and in healthcare. So it's difficult to make the change from kind of like the bottom up. So I think if we have the right evidence and we have the information, we can make a stronger argument to kind of like change that setting. And I think there's some work that we're doing in that space, but that's probably where we can continue to grow. And I know there are some, I guess, formally like implementation scientists and policy scientists in the unit that have been kind of like coming up later. But I think it's just the natural process of kind of like having designers that can help us think about how things can be in the future, having the clinicians, researchers doing the work, but now we need to then use it for change.
I think point well taken. I mean, Jennifer Ridgway and has led us with Victor and I and others into projects with implementation science, and we bump into the way healthcare is structured more than the nature of the intervention or anything else as a challenge. David, you want to add something? You want a microphone?
No, but I can take it, yeah.
To change the batteries, might as well use it.
I just wanted to add that as someone who's just kind of joining the unit, and one of the aspects that I feel like we do a lot is try to fix what's already broken. And a lot of the things are trying to look at like what's been a problem over the last 15, 20 years. But I would love to see more of anticipating what's going to be a problem in the next 10 and 20 years and try to have an impact in the way it works before it actually becomes a problem. And one of the reasons why I see this is because the way our young patients interact with us as physicians is just not the same as a 40, 50, 60-year-old patient. And when we're doing work, for example, in shared decision making and looking at these tools that actually require the patient and provider to be in the same room, the reality is 20 years old don't want to be in that room with you. If that tool doesn't feed their needs, but you still need to find a way to provide caring and compassionate care that feeds their goals and try to meet them there. So how can we harvest all of these other technologies? How do we do care that feeds asynchronously, which is not the traditional way we think about it, but it might be the way the younger people want to approach their care. So I also feel we need to find a way to meet them there and try to be an active role in shaping how it works before it becomes a problem that we will then have to fix.
Yeah, so it's an interesting exercise that of predicting the future, right? So is it that people are going to be completely digital in the way they interact because that's something they prefer or want, or they grew up with, or that is dictated by the, those who get to dictate what popular culture is or so forth? Or maybe we predict that there will be a renaissance. So people want to spend time in sitting around the table and, I mean, Paul, I mean, I don't know why I thought sitting around a table and I thought about Paul Bar, but but there's a lot that happens when we come together. In fact, you're all here, right? And there's a lot that happens when we are together in person. And I wonder if there will be, I mean, another prediction one could make is that there will be a backlash, right? And that we will reject it, living through a digital lens and try to find ways of finding each other. And so for which one do we design? For which one do we investigate? I think that's a great challenge to have.
Can I just add?
No,
Yes.
no,
No.
no, hold on. Lori from online asked a question that I think is also another potential direction, which is, why have we focused on trying to do interventions in healthcare? Is our encounter research focus too narrow? What about what about weaponizing patients to try to get healthcare to behave, right? Why haven't we pursued the approach of more education of patients or more training of patients so they can get these darn clinicians to share decisions with them? Why haven't we done that, right? Is that a missed opportunity? Or others might say, well, because patients are not a means. right? And so you don't get to weaponize it. You don't get to use them to change healthcare. You know, they're coming for healthcare for care, and you don't get to use them. So that's another potential debate for us to have. Do you really? Okay, go ahead.
Because I think, I mean, well, so it answers your question and it answers David, what you were saying of, I think the assumption also is that patients are going to continue to just come to us for healthcare answers, that they're just going to interact with us. And it made me think, I said to Maggie, when you were talking about, like, we did a Tupperware mammogram. So we were trying to talk to women.
It's not a Tupperware mammogram.
No.
I don't know what you're thinking right now, what a
It's
Tupperware
like a
mammogram
Tupperware
is.
party, but we brought women together to have a conversation about what mammography. So I said the Tupperware part, but because that was always what Victor called it, the Tupperware mammogram, which again, it was
I
not
never
that.
called it out.
Yeah, you did. But again, this concept of we were there just to facilitate the conversation a little bit. But again, it was intended to bring women together that are around that age of having the conversation of whether to proceed with mammography and what would that conversation look like, or how could it occur in a community or in a setting. And again, I think it's already happening. I think that there's also, best word I can say is lack of trust or concerns with incorrect or insufficient information. So patients are already coming in. So I'd say for that weaponized part, they are coming in with this, and many are frustrated with the responses and or answers that they see. And most are missed because, again, they're not the ones that are going to necessarily sign up for our research project, or our research projects that are contained just within the medical system. And they only come in at their, most desperate or dire times, but people are trying to weaponize themselves and or are trying to get that information. So I would say in the world also of AI is how to leverage or understand those other resources that patients are utilizing to inform themselves and or educate themselves on things that maybe have not been how we were traditionally trained or taught.
Yeah.
And I'll just say Patient Revolution took the mammogram Tupperware party idea and grew it and has expanded it to other conditions as well. We've done a whole series of it around women's cardiac health. Now we're getting ready to also kind of move into perimenopause kind of space and menopause space. That's another paper that we've written that we can't get published because I think how we structured it and what we learned from it just doesn't fit into what academic journals are looking for.
Funded by the Container Store at this point.
Maybe one comment, one comment and one metaphor, but are we, I feel like in focusing on the encounters, it's been about the illness, and that's okay to be looking at that illness. And you're talking about weaponize. Is it weaponizing patients or empowering them? And is it turning illness into wellness? Because I was looking at Angela moved in, and made me think of our OBNES projects and program, which was another project that Victor said, don't do it. And don't do this bad idea. And now it's embedded within the Mayo Clinic, Mayo Health System, and others. But that was about actually removing the encounters. So it was about removing the encounters, removing care, because pregnancy had become an illness, had become a way that you need to be monitored constantly. So we turned it around and trying to think in terms of what's not needed and what are we doing too much of, and what can we do that. And that brings me to the metaphor of, I was reading this article in the New York Times recently, and it was talking about racing and the Olympics and everything, and about how if you look at what's been happening with racing, it's amazing to see all of the work that people are doing to get all of those suits ready, and the shoes and the starters, and think of all the research that's been done designing the best fiber and training and ways in nutrition to get those runner the fastest 9 whatever seconds it takes to do the 100-meter, and we've been focusing on that. So thinking about as this work around the work of the encounters, yet why is that bid still there? Why do we still pin, with years and years and years of research, they still go and pin that bid with on their self, which then slows them down. So and the reflection in that piece of paper, which I keep bringing back in my own reflection, is, are we forgetting the obvious? what is it, what has been there forever that we just keep using because it has been normalized, and it's kind of that elephant in the room that we've forgotten about it. So that's what I'm just thinking in terms of the unit and where we should going next. You know, where is our bid? Where is the bit that needs to be removed that we've forgotten and that it's there and it shouldn't be and doesn't bring value? It needs to be, you know, removed so that we can focus on something more efficient. So just.
Are there questions in the room? Yes, there's a question over there. Can we run with microphones? Yeah.
Segue because
It's off, it's off, it's off.
David, the perfect segue because I was recalling something that you had said on Monday too, this notion of decluttering. I know that search engines have worked over the years to try to eliminate when someone's doing a search, the less reputable sort of things are less likely to show up, and things that come from medical journals are supposed to appear at the top. But I also think about still all with the new standards that we come up with and new guidelines, the old ones are still in there and they're still going to pop up. And when whether we talk about weaponizing or empowering patients, they're coming to us with information. Is there a way that we can declutter and not necessarily dispose of, but maybe put aside or archive those things that we want to not eliminate, but we want to focus on what's the best practices and what's the most current research is showing that we need to do?
See if there's any other question to that. Oh, there's more. Go ahead. I won't comment. Go ahead. Keep talking. It would activate itself, I think, or not.
It's all right.
Oh, no, you don't. This one is working, I think.
There we go.
Yeah.
Okay. So sort of towards the designer and sort of the team over the years since you've joined, how have you been able to expand the design practice and sort of teach the team and have them believe it as well? Like, what have you done? Like, how have you bolstered yourself into that approach and have them learn as well? Because I feel like there could be a bit of a stagnation or like some stillness being in a silo.
Oh, it's such
Very
an
brief
interesting.
answer.
Well, I don't know. It's a great question. I mean, I think I've continued to work with this community of people, but in a different practice, meaning so now I work for the kind of nonprofit partner for Patient Revolution, which is kind of that's a little bit how I think of it. I think we're always finding in that work, I find that I have different constraints that I have to work under, and that kind of helps fuel my practice. I also, I'm similarly to here and the role I think of researchers, I'm able to have an idea and try and figure out how to advance it and who can I work with to kind of learn about it. I think you can see, I think a lot of the evolution of design within the care unit has come from Ian's more permanent role here. I was always kind of a occasional in and out. And Ian has his PhD in design. I only have my master's, and he's got a much greater grasp of some of the underlying ideas and theories that animate design. And I think he's brought those to people in a way that is continually challenging the work that happens here. And that is what has kind of introduced a different language and kind of kept it advancing, is a lot of what I would say about design within this practice, in ways that I don't think design gets to live in many places, because a lot of design happens in a more of a kind of corporate or consulting sort of framework. So this is a very unique kind of petri dish. And again, it would be really amazing to understand more about what it has meant. This would be a great place to do an ethnographic research on the role of embedding design within a group.
Oh,
Hi, no, thanks. So on the theme of rejection, I'm barred from joining the care unit, so I only ever look in. Victor considered me to be too disruptive. But I think it was our first Pisco Sour of God, 12 years ago in Lima. In terms of the care unit and you guys going forwards, and one thing is talking about change, don't change is how you work as a team. Because as an outsider who has the good fortune to dip in now and again and join you all, it's so inspiring how you do work and communicate together. And I'm always humbled by how little I know when I come and talk to you all, how much I learn, but also your generosity and how you'll support that. And I'm so grateful for it. In terms of strategically, I think there needs to be a big focus on funders so that all the work over the last lot of years to amplify the work that you all lead and allow it to get the recognition with people who are giving the money to support that work, that it doesn't get drowned out by other interests and technology developments which become to the fore. So how do you strategically influence people with the purse strings in the government at NIH, at PCORI, elsewhere, to keep the work at the forefront?
I want to finish. I'm sure there will be more discussion, but the food is in the back and it's beginning to smell. And yeah, and so, but I want to finish with a couple of reflections. One is I want to recognize the care unit today. We've been looking back, but the Ian, which has been mentioned, Juan Pablo, Casey, Mike, David just joining, and investigators who are trusting our unit with their careers to go further. There's a bunch of young people that you've met that are helping us put this conference together, and they're trusting their careers, and they're trusting that this magic will happen to them thanks to their interaction with some of the colleagues I have mentioned. And so we're very grateful, actually, that they trust us with their destiny. The topic of rejection did come through quite a bit. Thanks, Oscar. And but it catches me at an interesting time because I'm finding myself self-rejecting now. This is the ideas and things that I have been considering have not really captured my imagination, and I've responded with meh to many of those. So I'm finding myself at this point mostly supporting the brilliant ideas that other people have rather than pursuing my own. So I think from all that practice, eventually I just got really good at that, and now I'm applying it to myself. So in part, this exercise of knowing where to go next is actually really helpful to me, as it is the whole conference and the generosity by which the participants have been sharing where they're going with these things. Healthcare is in deep trouble, and whether the clinical encounter disappears or becomes a metaphor for patients and clinicians coming together to advance the problematic situation of the patient, to co-create a plan of care that makes sense to them, that fits in their life, whether that happens in an encounter or happens elsewhere, I think it will continue to be, I think, the most professionalized version of something that we hope our societies and our communities will do, which is that in every possibility of humans interacting, our first instinct is not going to be to harm, but our first instinct will be to care. And how we can do that professionally, how do we get to do that professionally, how do we get to investigate, how do we get to have a research career or a caring career focused on care? I mean, that's just a massive privilege, right? It's an incredible luck. So I hope this reflection was helpful. I hope this reflection conveyed profound three truths. One, we need more space where our space is too small. Two, I am the luckiest researcher in the world. And three, you meet my family tonight, I think. Some of it, my wife mostly, and Victor you've met, and the other joined college. But and you meet the dog, Bruno, and who's scared of storms and might not be around. But for those of you who are not in the care unit, you're leaving my family, and I'm the luckiest. Thank you.
Now I have to. Everyone, one, thank you for attending this session. It's really important and wonderful for you all to be here and help us reflect on these values that have meant so much to us.